Welcome. My name is Gersy, and today I'm presenting an evidence-based assessment proposal for improving care transitions for heart failure patients at a 250-bed community hospital. This proposal applies experience-based co-design, or EBCD, a participatory quality improvement methodology that centers the lived experiences of patients and frontline staff. Over the next several minutes, I'll walk you through the problem, the proposed approach, the measures and analysis plan, and the anticipated impact. Let me set the stage. This proposal is situated in a 250-bed community hospital with a high Medicare population, a group at elevated risk for heart failure readmissions. The hospital participates in CMS's Hospital Readmissions Reduction Program, which means readmission performance directly affects reimbursement. In the pilot unit, we see approximately 12 CHF discharges per week, giving us a manageable but statistically meaningful sample. Our current 30-day readmission rate of 22% exceeds the national CMS benchmark of roughly 20%, which signals a clear and addressable performance gap. The data tells a clear story about a systemic problem. 22% of CHF patients are returning within 30 days, above the national benchmark. Only 59% complete a 7-day follow-up appointment, despite strong evidence that early follow-up significantly reduces readmission risk. Over a third of patients report confusion about their discharge instructions, and medication discrepancies are a recurring issue. Together, these metrics point not to individual failures, but to a reliability problem in how we transition patients out of the hospital and into community care. Why does this matter beyond the clinical? First, the financial exposure. CMS can penalize hospitals up to 3% of Medicare payments under HRRP for excess readmissions. Second, the human cost. Readmissions are associated with increased mortality and morbidity. Third, patient satisfaction and CAHPS scores are directly tied to how patients experience their discharge. And finally, preventable readmissions are a signal of workflow inefficiency that burdens staff and consumes bed capacity. This is fundamentally a management and operational challenge, not just a clinical one. Our SMART objective is built around two measurable targets to be achieved by week 12 of the pilot. First, increase 7-day follow-up completion from 59% to 80%. Second, reduce the 30-day CHF readmission rate from 22% to 17%. Both targets are grounded in the literature and represent clinically meaningful thresholds. The 5-point reduction in readmissions, while modest, would reduce HRRP penalty exposure and have meaningful downstream effects on patient outcomes. The follow-up target of 80% is based on AHRQ benchmarks for high-performing transition programs. This proposal is grounded in a strong evidence base. CMS data confirms that CHF readmissions remain persistently high nationally. A HRQ research identifies transitional care failures as a primary driver of those readmissions. The foundational EBCD framework comes from Bate and Roberts' seminal 2006 work on co-designing services with patients. More recently, Greenhalgh and colleagues in 2021 demonstrated that participatory redesign approaches improve both fidelity and sustainability of implementation. And the broader literature consistently links structured 7-day follow-up to reduced readmission risk. I want to highlight that we have sources spanning 2006 through 2023, with 2 within the past 5 years, Greenhalgh 2021 and Lowcock 2020. Traditional quality improvement tends to be top-down. Administrators and clinical leaders map processes and mandate changes. EBCD flips that model. It starts by capturing the emotional and experiential reality of patients and staff, what we call touch points, and then brings those groups together to co-design solutions. The research shows that interventions designed this way have higher buy-in, are better adapted to real-world workflows, and are more sustainable over time. For a problem like care transitions, where the breakdown happens at the intersection of clinical, logistical, and communication systems, EBCD is a particularly well-suited methodology. Phase 1 is about building our stakeholder group. We'll recruit 10 recently discharged CHF patients and 5 caregivers, the people who lived the transition experience. We'll also engage 4 nurses, 3 case managers, 2 cardiologists, a pharmacist, and a scheduler, the frontline team responsible for executing discharge processes. Sampling will focus on CHF discharges within the past 30 days from the pilot unit to ensure experiences are current and relevant. This diverse group ensures that co-design sessions reflect the full range of perspectives involved in transitions. Phase 2 is where we gather data to understand the problem deeply before designing solutions. We'll use 4 methods: semi-structured patient interviews to surface emotional experiences and barriers, staff focus groups to capture workflow perspectives, direct observation of discharge workflows to identify process gaps in real time, and a review of transitional documentation, including discharge summaries and medication reconciliation forms. The goal is not just to count what goes wrong, but to understand why, and to identify the specific moments where patients feel most confused, anxious, or unsupported. Based on the literature and preliminary operational data, we anticipate 5 key transitional touchpoints will emerge from Phase 2. Information overload at discharge. Patients receiving large volumes of paperwork without structured guidance. Medication confusion. Contradictory or unclear instructions between providers. Follow-up scheduling delays. Appointments not confirmed before the patient leaves. Caregiver uncertainty. Family members excluded from discharge education. And a lack of early post-discharge contact. No structured check-in in the critical first 48 to 72 hours. These are the pressure points our co-design sessions will target. The co-design phase is the heart of EBCD. In Session 1, patients, caregivers, and staff jointly prioritize the top 3 experience breakdowns from our Phase 2 findings. In Session 2, this same mixed group develops prototype interventions. Our anticipated interventions are mandatory scheduling of 7-day follow-up appointments before discharge, embedding a teach-back checklist directly in the EHR, creating a simplified, plain-language CHF discharge summary, and implementing a structured 48-hour nurse follow-up call. These are not top-down mandates. They are solutions built by the people who experience the process every day. The pilot will run for 4 weeks on one medical/telemetry unit, capturing approximately 48 CHF discharges. Before launch, all participating staff will receive training on the co-designed interventions. During the pilot, we'll monitor performance in real time using weekly run charts and hold daily huddles with charge nurses and case managers to surface issues early. This single unit focus allows us to test the interventions in a controlled setting before recommending scale across the hospital. This driver diagram maps our aim to the primary and secondary drivers of transitional care reliability. Our overarching aim is to reduce 30-day readmissions from 22% to 17% and increase 7-day follow-up from 59% to 80%. The 4 primary drivers are a reliable discharge process, medication reconciliation accuracy, cross-continuum communication, and, at the core of EBCD, patient experience integration. Each driver connects to specific secondary interventions that the pilot will test. This diagram serves as our theory of change and guides how we measure progress. We're using a balanced measurement framework across 3 categories. Outcome measures tell us whether patients are doing better. Readmission rate, follow-up completion, and patient understanding scores. Process measures tell us whether the interventions are being executed, teach-back documentation, pre-discharge scheduling, and 48-hour call completion rates. Balancing measures protect against unintended consequences. We're monitoring discharge processing time, case manager workload, and length of stay to ensure we're not solving one problem by creating another. This balanced approach is essential for credible, leadership-ready reporting. Our data strategy uses multiple sources to triangulate findings. EHR readmission reports and scheduling logs provide objective process and outcome data. CMS Hospital Compare gives us national benchmark context. Post-discharge telephone surveys capture patient-reported outcomes, and interview transcripts from the EBCD phase provide the qualitative depth needed to explain the quantitative trends. Using both EHR data and patient-reported data strengthens the rigor of our analysis and allows us to tell a complete story about what changed and why. Our quantitative plan compares 4 weeks of baseline data against 4 weeks of pilot data, approximately 48 patients in each period. We'll use run charts to track weekly trends and identify signals of improvement above baseline noise, using established run chart rules, such as 6 or more consecutive data points above or below the median. For follow-up completion, we'll run a chi-squared test at alpha equals 0.05. For the leadership interpretation framework, we've predefined our decision thresholds. A 5-point reduction in readmissions and a 21-point gain in follow-up are our meaningful targets. And our decision rule is clear. If 2 of 3 primary process measures show sustained improvement by week 12, leadership will receive a recommendation to scale. On the qualitative side, interview transcripts will be analyzed using thematic analysis, a systematic approach to identifying patterns across patient and caregiver narratives. To ensure rigor, 2 independent coders will analyze the data separately, then meet to reconcile discrepancies and finalize a shared codebook. The resulting themes will be directly mapped back to transitional touchpoints, creating a clear line between what patients experienced and what interventions we designed to address it. This dual coder approach is a recognized marker of methodological trustworthiness in qualitative health services research. This project is designed to be feasible within existing organizational capacity. The 12-week timeline is realistic given the scope. As a quality improvement initiative, it will likely qualify for IRB exemption, though we'll confirm with the Institutional Review Office. All interviews and focus groups will require informed consent, and patient data will be handled in full HIPAA compliance. Participation is entirely voluntary. The resources needed are targeted: a QI facilitator, part-time data analyst support, and protected staff time for training and co-design sessions, all manageable within a pilot budget. The 12-week timeline is structured to move efficiently through each EBCD phase without sacrificing rigor. Weeks 1 and 2 focus on stakeholder recruitment. Weeks 3 and 4 are for interviews and workflow observation. Week 5 is dedicated to thematic synthesis, bringing together qualitative findings to identify priority touchpoints. Weeks 6 and 7 are the co-design sessions where patients and staff prototype solutions together. Weeks 8 through 11 are the active pilot And week 12 is evaluation and the leadership presentation. This timeline is tight but achievable and builds in reflection time between each phase. In the short term, we expect to see measurable improvements in follow-up reliability and discharge clarity. In the intermediate term, as the process changes take hold, we anticipate a reduction in preventable readmissions, and in the long term, this pilot establishes a replicable model. Reduced HRRP penalties protect revenue. Improved CAHPS scores strengthen reputation and patient loyalty. And perhaps most importantly, a scalable EBCD-informed transitional care model can be spread to other units and adapted for other high-risk populations, creating lasting organizational value beyond this single pilot. Findings will be communicated across multiple channels appropriate to each audience. An executive dashboard presentation will bring data and recommendations to hospital leadership. A unit-level feedback session will give the frontline team, the nurses, case managers, and staff who participated direct access to what we learned. A formal quality committee report will document findings and recommendations for organizational record and spread planning, and a patient-facing infographic will share outcomes with the Patient Advisory Council, closing the loop with the community whose experience drove this work. I want to be transparent about the limitations of this design. The pilot sample of approximately 48 patients per period limits statistical power, particularly for detecting changes in readmission rates, which is why we've pre-specified readmissions as a trend outcome rather than a primary statistical test. The 4-week window is short for observing 30-day outcomes in real time. External confounders like seasonal census variation and concurrent QI initiatives may influence results. And 48-hour follow-up calls depend on nurse capacity, which can fluctuate. Our primary success metrics are the process measures, which are more sensitive to short-term change and directly actionable by leadership. Finally, elevated CHF readmissions at this hospital reflect a system-level failure in transitional care, not individual clinical shortcomings. Applying experience-based co-design gives us a structured, evidence-based path forward, engaging the right stakeholders, capturing the real experiences of patients and staff, redesigning the moments that matter most, and testing those changes in a rigorous pilot. This is a 12-week investment with the potential to reduce readmission penalties, improve patient outcomes, and build a scalable model of transitional care reliability. I'm confident this approach can deliver meaningful results, and I welcome your questions. This slide contains all references in APA7 format. The evidence base includes 8 sources spanning foundational EBCD literature, CMS and AHRQ benchmarks, and recent peer-reviewed research on readmission prediction and participatory improvement. Of note, Greenhalgh and colleagues 2021 and Lowcock and colleagues 2020 are within the past 5 years, meeting the rubric requirement for current sources in this assignment. All sources are directly tied to the problem definition, methodology, or analytic approach presented in this proposal. This appendix provides the complete measures table required by the rubric. All 9 measures are operationally defined: 3 outcome, 3 process, and 3 balancing measures. Each entry includes the precise definition used for data collection, the specific data source, and the collection frequency. This level of specificity is essential for leadership to understand exactly what is being measured, where the data comes from, and how often it will be reported. The color coding, green for outcome, teal for process, orange for balancing, mirrors the framework used throughout the presentation for consistency.